Good morning, good afternoon to everyone. Welcome. My name is Nina Bohl and I'm a health counselor at the Embassy of Denmark in Korea. It's my honor and pleasure to lead you through a row of impressive speakers today. Today's webinar is on the patient-centered approach, which Healthcare Denmark has produced a paper on. This has been translated to Korean and has also been shared with all of you as part of the invitation to the webinar. First of all, I'd like to hand over to our ambassador, the ambassador of Denmark to Korea, His Excellency Einar Jensen.
Ladies and gentlemen, good morning and good afternoon to you. And to all of you, and welcome to this webinar on patient-centered approach in the primary healthcare. As the Ambassador of Denmark in Korea, I'm very pleased to be hosting today's event, which is the second in our series of seminars on primary healthcare. I would like to start by thanking all of today's speakers for taking the time to join us for a conversation on this very important topic. In particular, I would like to say a special thanks to the Korean Ministry of Health and Welfare and the Danish Ministry of Health for their continued support in this dialogue. Furthermore, I would like to thank the Korean National Assembly member, Ms. Choi, and the member of the Danish Parliament, Ms. Heidemann, for their high-level remarks, which we will hear just in a few minutes. We are delighted that you have taken the time to address us, and we are proud that you are with us today. The Danish-Korean healthcare system face similar challenges. We both have low birth rates, aging population, and more chronic diseases. 1 of 3 Danes above the age of 16 suffer from 1 or more chronic diseases, while in Korea 67% of people in their 50s have at least 1 chronic disease. This number only grows with the increasing age. We have many innovative new solutions for treatments in the healthcare sector, and we have many dedicated nurses, doctors, and other healthcare personnel. But we remain with limited resources, so we need to find our ways in this scenario. Therefore, we need to take an innovative approach and think of new integrated care solutions. We need to realize that private-public partnerships can help us in delivering personalized patient support and obtaining the full value of our treatment to the benefit of our patients. We have many examples of this. The Danish company Coloplast engages with municipalities to optimize product choice and usage through close support for patients living with ostomy. Living with ostomy often implies the need for continuous support throughout the patient's life, and therefore the care program rolled out by Coloplast is so important in that the initiative helps patients better manage their conditions to live a normal life, which increases their quality of life and again reducing demands on the healthcare system for the benefit of both sides, especially the patients. Other examples are Leo Pharma, who has introduced an application which reduces bottlenecks in the diagnosis of scabies, and Danish municipalities have commissioned a digital platform that increases level of care and reduces cost of chronic care in a collaboration with Liva Healthcare. These are just a few examples of the solutions which are described in Healthcare Denmark's recent publication, the III paper, which I hope you have all received in a digital or hard copy version. If not, it can be downloaded from their website. It is crucial that we understand the needs of our patients, that we place them at the center of their own treatment journey, and that we utilize public-private partnerships to their benefit. I am looking forward to our discussion on this subject today, So stay with us, and there will be a couple of exciting hours. Thank you very much. 감사합니다.
Thank you very much, Ambassador, for your opening remarks. We will now turn to our first keynote speaker, Ms. Yoon Suk Che. Ms. Che is a nurse and a member of the National Assembly of the Republic of Korea. In this capacity, she's part of the Health and Welfare Committee, as well as the Gender Equality and Family Committee.
안녕하십니까. 국회 보건복지위원회 국회의원 국민의당 최은숙입니다. 오늘 1차 의료에서의 환자 중심 접근이라는 주제로 한국, 덴마크 보건의료 포럼을 개최하게 된 것을 진심으로 축하드리며 저에게 키노트 스피치 기회를 주셔서 감사드립니다. 저는 대구에 있는 계명대학교 동산병원에서 38년간 간호사로 근무하다가 작년 초에 코로나19를 맞았습니다. 대구 경북 지역에서 초기 대유행이 발생하자 대구 동산병원이 감염병 전담병원으로 지정됐고 약 3개월간 간호부원장으로서 병원과 간호 분야의 감염병 대응 체계를 새롭게 만들고 미지의 감염병과 사투를 벌였습니다. 코로나에 하루하루 대응하면서 깨달은 것은 신종 감염병은 고령의 만성질환자에게 치명적이라는 것이었습니다. 정부는 고령자와 만성질환자를 관리함으로써 이들의 감염병 등 각종 질환에서 중증으로의 전환과 사망을 막아야 합니다. 국민이 건강한 상태로 지속적으로 삶을 유지하도록 정책과 제도를 만들어야 합니다. 대한민국 보건의료는 인구 고령화, 질병 구조의 변화, 국민 의료비 급증 등의 문제에 직면해 있습니다. 이러한 문제는 치료 중심의 보건의료 체계를 질병 예방과 만성질환 관리 중심으로 전환하고 사람과 지역 중심으로 보건의료 시스템을 혁신하여 해결해 나가야 합니다. 우리나라 정부나 학계, 전문가 단체 등은 우리나라보다 앞서 고령화와 만성질환자 증가를 경험한 덴마크 등 북유럽 국가들이 지역사회 돌봄과 1차 의료의 강화를 통해 만성 환자를 관리하고 의료비를 절감한 것에 큰 관심을 갖고 있습니다. 대한간호협회도 2018년부터 덴마크 간호협회와 지역사회 간호서비스 강화를 위한 방안을 모색하기 위해 지속적으로 교류하였고 이러한 인연을 계기로 오늘의 이 포럼이 개최된 것으로 알고 있습니다. 이러한 반성과 학습을 토대로 대한민국 보건의료 시스템은 보건의료 패러다임 변화에 맞춰 혁신해야 할 것입니다. 첫째, 급성기 질환의 의료기관에서 만성질환 관리의 지역사회 중심으로 변경되어야 합니다. 만성질환은 꾸준한 관리가 핵심입니다. 환자의 상태를 지속적으로 파악하고 있는 의료인이 환자 스스로 증상 개선을 위해 지속적으로 활동할 수 있도록 지원을 해야 합니다. 또한 정부는 약물 투여, 영양 및 운동 등 생활 습관 개선을 복합적으로 상담하고 관리할 수 있는 장을 만들어야 하며 여기에서 다양한 전문 인력이 협력하는 시스템도 만들어야 합니다. 현재 1차 의료기관 중심으로 시행하고 있는 만성질환 사업을 전환하여 지역사회 의료기관과 지역 내 돌봄기관, 공공기관이 협력하는 시스템을 만들어야 합니다. 우선적으로 먼저 공공부문, 특히 보건소 등의 건강정지 사업이 활성화될 수 있는 체계를 마련해야 합니다. 둘째는 보건의료인과 돌봄 인력 간의 상호협력입니다. 우리나라 지역사회에서는 의료와 돌봄의 기능이 분화되어 있습니다. 그러나 현장에는 의료와 돌봄의 문제가 분리되지 않는 경우가 많이 발생하고 있습니다. 이러한 문제의 해결을 위해 외국에서는 간호를 가장 많이 활용하였습니다. 일례로 간호사와 요양보호사가 협력하여 의료와 돌봄 문제를 1차적으로 해결하고 위중하고 심각한 문제를 발견하면 간호사가 의사나 의료기관과 연결하는 시스템을 만들었습니다. 덴마크도 구마다 방문간호센터가 있어 지역의 노인과 만성질환자를 돌보고 있는 것으로 알고 있습니다. 그러나 우리나라는 아직도 지역사회 방문간호가 활성화되지 못하고 있고 지역사회에서 간호와 돌봄을 수행할 간호법조차 만들어져 있지 못해 이를 실현하기가 어려운 상태입니다. 이에 고령화와 질병구조 변화에 대한 보건의료 전달 체계를 혁신하는 정책 대안은 국민건강 정지를 위한 간호법을 제정하는 것입니다. 간호법은 돌봄 인력, 즉 간호사, 전문간호사, 간호보조 인력 모두를 포괄하는 것이며 의료기관에만 그 적용이 한정되었던 의료법 체계를 벗어나 대한민국 모든 지역에 적용되는 것이며 지역에서의 만성질환 관리를 위한 간호 업무와 인력 기준 등을 제공하는 등 법적, 제도적 기반이 될 것입니다. 우리나라뿐 아니라 세계 보건의료 패러다임은 치료 중심에서 질병과 만성질환 관리로 전환이 이루어지고 있습니다. 4, 5년마다 감염병이 유행하고 있고 지역사회에서 감염 예방 교육 등 지속적인 공중보건 등의 관리를 해야 할 시대가 도래하고 있습니다. 정부는 국민의 건강과 만성질환 관리를 위하여 지역사회에서의 1차 의료와 돌봄이 협력하여 기능할 수 있는 체계를 만들어야 할 것입니다. 오늘 이 포럼이 한국과 덴마크가 지역사회 보건의료 발전을 위해 한층 더 협력하는 계기가 되기를 바랍니다. 감사합니다.
Thank you. We are very grateful for Ms. Chess' remarks. We will now hear a keynote speech from a Danish parliamentarian. Ms. Jane Heitmann is currently serving as chair of the Danish Parliament's Health and Senior Citizens Committee and is her party's spokesperson for health and senior citizens.
Thank you very much for the invitation to speak today. My name is Jane Heitmann. I'm a member of the Danish Parliament and I'm the chairman of the Health Committee. It is a great pleasure for me to participate in these knowledge sharing seminars where we can exchange experience and together rethink healthcare and create even better conditions for patients around the world. First, I would like to thank Member of the National Assembly, Mrs. Cho Young-suk, for her remarks. Your positive words about Denmark are greatly appreciated. I would also like to congratulate you and your country on Korea's impressive handling of the COVID-19 pandemic. You have been well prepared and you have been able to strike a balance of keeping the infections under control while still keeping large parts of the society open. You have served as an example and inspiration to many countries. Furthermore, we are pleased with the close collaboration that our two countries have had since 2013 regarding healthcare. Korea has an impressive pace when it comes to improving healthcare, and this brings many opportunities for us to learn from Korea as well as to showcase our own experience and Danish solutions to the challenges that we share. The Danish royal visit to Korea in 2019 to celebrate 60 years of diplomatic ties further underlined the close collaboration between our countries, which we will continue to build on in the future. Just before the world closed down with COVID-19, I had the pleasure to welcoming a delegation from, among others, the National Assembly of Korea to the Danish Parliament, where we had an interesting talk about the mental health and suicide prevention. This is a subject of great concern in Korea and something that we in Denmark have worked actively with for many years. I know that the great collaboration between Korea and Denmark on this important subject is still ongoing and brings value to both of our countries. The New Deal initiative in Korea, and especially the activities concerning smart hospitals, is very exciting and something that we will follow with huge interest. In Denmark, we have quite a lot of experience with smart hospitals, and we look forward to sharing some of these with Korea, as well as to be inspired by your approach and your advanced technological solutions. As most other countries in the world, we are challenged by the increasing number of patients with chronic diseases. Healthcare systems around the world are stretched to the limits, and we need to think out of the box to take a different approach to solve the challenge. In Denmark, we see the strong private-public collaboration as one of the solutions to this. We have a well-functioning public healthcare system in Denmark, but there is still a lot to do and we can still improve. We see the benefit of inviting private players to bring innovative solutions that can take some of the pressure off the healthcare system. These solutions range from remote handling of blood sampling and tests to diagnostics apps and personal support through digital solutions, just to mention some. These strategic partnerships have fostered more health as well as more research and resulted in integrated health solutions that benefits both the patients and the society. Health and well-being are some of the keys to growth, and investing upfront in better health as an investment that will pay off in the long perspective. A common feature for all these new patient solutions is that they have been developed with a patient-centric approach. In Denmark, we have a long tradition of putting the patient in the center. When new medicine and medtech solutions are developed, when we optimize the processes handling patients in the healthcare system. Too often, the patient falls between the responsibilities areas of the various parts of the healthcare system. The patient might be lost between treatment processes in the municipality and in the region. And the best way to improve this is to view the processes from a patient perspective. The healthcare system exists for the sake of the patient, not for the system. We want the patients to feel that there is a coherence in health offerings. They should get personalized treatment, and that they should have clear rights, as, for example, with the treatment guarantee of 30 days, which protects the patients against undignified treatment and long waiting times at the hospital. The value of remote or digital handling of patients has proven even more important during the last year with COVID-19. As I already mentioned, the Korean way of handling the pandemic has been very impressive and inspiring to follow and to learn from for us in Denmark. In our own country, we have once more seen the value of a strong public-private collaboration in the fight against COVID-19. The collaboration with private players has enabled us to increase test capacity considerably and thereby get the pandemic somewhat under control. By joining the forces of our public healthcare system with skilled and experienced personnel with innovative solutions from private companies that are on the forefront of scientific and technological development, we can take some of the pressure off the healthcare system and offer the newest and the most effective solutions to the citizens. I hope that you will enjoy the seminar today, and thank you for your attention.
Thank you very much. We greatly appreciate that Member of Parliament, Jane Heitmann, has taken her time to address us. We will now turn to our first speaker, Ms. Gerda Marie Rist, who is Chief Consultant at Healthcare Denmark. Ms. Rist has more than 15 years of experience in the health and life science area, and she will present on the Danish approach to personalized patient support. Please, Ms. Rist, the floor is yours.
Thank you very much. I'll just share my screen and make sure everything works here. So, can you see my screen now?
Yes.
Great.
Yes.
Okay, thank you very much for the invitation to speak today. It's a great pleasure to be here. My name is Gerda Marie Rist, and I'm from Healthcare Denmark. And today I will talk about personalized patient support in public-private partnerships. So, first of all, just to set the scene, I'd like to show you these two scenarios. In Denmark, like in most other countries, as you have also heard from the introductions here, there's a large pressure on the public healthcare system, partly due to the enormous rise of chronic patients. And you are probably familiar with these two scenarios. To the left, you see a demographic overview showing a shift towards more elderly people. You can see 1980 to the left and 2020 to the right. This is Danish numbers. And you can see how the volume is increasing on the top where you have the older generation. And to the right, the cartoon shows the change in our lifestyle. Less exercise, we are sitting at the computer and eating more unhealthy food, which gives rise to more chronic conditions. So this leads to increased expenses for our society, and it's a large burden for the healthcare system. So we need to find new ways to solve this. And there's a lot of focus on chronic patients in Denmark at the moment. We might actually get a political initiative later this year that deals with how to handle chronic patients. But that's another story which I hope I can tell you more about in the fall. So today I will focus on or touch upon 4 areas that we've had success with regarding chronic patients in Denmark. The first one is a strong public-private collaboration where the public healthcare system invites private companies to contribute with innovation. The second one is how we can realize the full value of treatment and get more out of existing and new products through patient support. Thirdly, how can we take care of more people with less resources using patient support solutions that take some of the pressure off the healthcare system? And finally, how we make sure that the patient needs are met by putting the patient in the center of all new innovation. So before I go into more details, I would just like to mention that all the examples that I will give today are described in this publication that was also mentioned earlier in the ambassador's introduction. It's about personalized patient support. You can see it here on the picture, and it's available in English and in Korean. You can find it on the Healthcare Denmark homepage as a PDF file, and it's also available as hard copies at the embassy. So I would like to play a short movie. It's just 1 minute about personalized patient support in Denmark, and then I will go into more details about how we approach this. So, the first focus area is about the strong public-private collaboration. There's a lot of political support to the public-private collaboration in Denmark. Because the public healthcare system is under such a huge pressure, private companies are invited to join with new ideas and solutions. And this is really a win-win-win situation because the patients will benefit from new medicine and apps and innovative support. And at the same time, some of the pressure on the healthcare system is removed. And finally, the private companies will get access to a large number of patients to test their new solutions. This is our Minister for Health, Magnus Heunicke, who is very occupied with patient-centric solutions and how to meet the increasing demands in the healthcare system. And in the foreword of the publication, the minister says, with patient support solutions, it's possible to tailor treatment to the patient's needs, thereby improving adherence, treatment outcomes, and efficacy. And this focus on meeting the patient's needs is something that's really high on the political agenda in Denmark. It's also really important that the policy framework conditions for such partnerships are in place. And this is Sofie Hestorp Andersen. She is the chairman of the Regional Council in the capital region of Denmark. And she says, our aim is to build a healthcare system where the needs of each individual person is at the center. An increased use of personalized healthcare technology is of great importance to achieve this, and furthermore help to use our limited resources in a more efficient manner. Public-private partnerships focusing on developing these new technologies are of vital importance. So this is an example of how the regional politicians are very supportive to the public-private partnerships. The capital region of Denmark is working with value-based procurement. So from being very focused on product cost only, we're now moving into a more holistic and value-based approach. And the capital region of Denmark has for several years used this value-based purchasing of the medtech equipment. And by the end of 2019, the life science industry and the public sector entered into an extended collaboration. A partnership was made between the Minister of Business, the Minister of Health, the purchasers from the regions and the municipalities, and a number of private companies. And together, these parties will improve the conditions for fostering innovation and freeing up resources to focus on the patient. This is a case from this procurement initiative that I just described. So this is a newly established company that develops home testing for kidney patients. And kidney patients have a suppressed immune system, so going to the hospital for them represents a risk because of the risk of infection. So home testing of biomarkers is a great solution. And at the same time, it frees up resources at the hospital, and the public healthcare system gets access to the newest technology. The second focus area is to realize the full value of treatment. Often the full value of the treatment is compromised by lack of adherence. Maybe the patient doesn't take the medicine in the right way, maybe not at all, or they use the equipment in the wrong way, or maybe they don't pick up the prescribed medicine at the pharmacy because maybe they feel uninformed about the side effects. So there are a lot of examples of how better information, personal support, and guidance can increase compliance and thereby also the efficacy dramatically. There is an urgent need to realize the full value of treatment. Just getting the most out of already marketed products holds a huge potential for the patient and of course also for our society. And this is an area where the private companies can play an important role in developing this support. I have two examples on the next pages from Danish companies who traditionally develop medicine or medtech products who have added a service element to their portfolio because they see that the patients have a big need for this. So The first one here is an example of personalized patient support from ALK. ALK is an allergy company that develops tablets and injectables for allergies like hay fever. And more than 500 million people live with allergy around the world. And this is causing a lot of extra sick leave and reduction in working capacity. ALK has developed an app called Clarify, where you get personalized allergy information. You can forecast relevant pollen information in your particular area. You can track symptoms, plan around your allergy, and also connect with relevant doctors. So this way, the patient will become more compliant and get the best out of existing medicine and solutions. The other example is from Coloplast, which was also presented before. Coloplast is a large medtech company that produces solutions for example, people with ostomy, which is a surgery that allows feces to be diverted out of the body through the abdomen, as you can see here on the picture with the lady who has this bag on her belly. So Coloplast has developed a support program called Coloplast Care. This is a combination of innovative products, personalized support, and direct-to-consumer delivery. And interestingly, when the patients get this support, there's a significant drop in hospital readmissions of 55%, which of course saves a lot of trouble for the patient and also a lot of money and resources for our society. The third focus area is about how we can care for more people with less resources. As mentioned, the increased pressure on the healthcare system often gives rise to bottlenecks at the general practitioner, at the hospitals, at the health centers, or at the specialists. Danish companies are developing new digital healthcare solutions to take some of that pressure off the public healthcare system. We see great collaboration between public and private partners, for example, in the two next cases. So this is a Danish company who has developed a digital solution for citizens with lifestyle-related illnesses. As mentioned in the beginning, we are challenged by the high number of citizens with chronic conditions. When we published this paper half a year ago, it was well known that 1 out of 3 Danes suffer from one or more chronic diseases. But recently, this number has proven to be even higher and maybe closer to 2 out of 3 Danes. So with this solution, you get access to a personal health coach through a digital solution. This increases the level of care for the patient and reduces the cost of chronic disease significantly. Just within diabetes, the municipalities can save more than $2,000 per citizen per year. And not least, the patients are very satisfied and get significantly health improvements. Another example is this app that can detect scabies infections. We have in Denmark seen an explosion in scabies cases recently, primarily among the young people at the boarding schools. This has resulted in long waiting lists at the dermatologists. But with this solution, the patient can take a photo of the infection, which is then assessed by a dermatologist. So this way, the conditions that are obviously not scabies can be referred to the GP instead, and the pressure on the dermatologist is decreased that way. Finally, the fourth focus area is about ensuring that the patient needs are actually met. So putting the patient in the center is key both in public and private healthcare and innovation. Patient organizations play an important role in the Nordic healthcare systems. They have a long tradition and are well organized with a strong influence on society. And also the health authorities recognize and value their opinion, for example, when we do the health technology assessments. This is an example from the Danish Psoriasis Association, who work closely with the industry in the development of new medicine and support solutions. And here's a statement from the CEO, Lars Werner, who says, In Denmark, we are very fortunate that the life science industry calls upon us as patient organizations to include patients in all phases of the development of pharmaceuticals and medical devices. I remember from my own time at Leo Pharma, where I spent 13 years of my career, that we often had patients visit us in the project teams to learn what the patients saw as the biggest problems and what was really bothering them in their everyday life. One time I was in a project group where our focus was to increase the efficacy of a psoriasis gel. But talking to the patient, it turned out that she was actually fine with the gel. She thought it worked very well, but her real problem was that we didn't have something for her nail psoriasis, and we didn't have any product for that, and that was really a huge problem for her. So that way we found out what was really important to focus on. I will end my talk with a small film with the CEO of the Danish Multiple Sclerosis Society, Claus Høm. And I think Claus Høm puts it very well when he says that one-size-fits-all solutions are rarely very good for the patient, for the individual patient. And that is why it's so crucial to involve the patient perspective.
As a patient with a chronic disease, for instance multiple sclerosis, it's obviously very important that you have access to the right medical treatment. But it's also important that the whole structure around you works well. One-size-fits-all solutions are rarely very good for the individual patient. And that's why it's so crucial to involve the patient perspective. And I think in Denmark that we are quite lucky that all parties, the healthcare industry, the authorities, the healthcare workers, and obviously the patients are working together to find the right solution. That is actually the key to success. Health is a global issue, and that's why we invite for a cross-country dialogue.
So, with that, I would like to thank you for your attention, and I hope you will enjoy the rest of the seminar. Thank you.
Thank you very much, Ms. Rist, for your presentation and for also sharing the patient perspective in your video. We will now turn to Professor Bilong Cho from the Seoul National University Hospital. Professor Cho has a long and very impressive career. He is currently serving as a professor at the Department of Family Medicine, and he will speak about initiatives to increase patient-centeredness in primary healthcare in Korea. Please, Professor Cho, the floor is yours.
Thank you for invitation and the good opportunity. I am Dr. Jo from Seoul, Korea, and Seoul National University Hospital, Department of Family Medicine. Today, I'd like to show you some initiatives to increase patient-centeredness in primary health care of Korea. Actually, there are many elements in the patient-centered care, such as primary care providers' mission and the value should be aligned with the patient goal, and the care should be collaborative and coordinated and accessible. And not only physical comfort, but emotional well-being should be top priorities. And the family and the patient viewpoint should be respected, and the patient and the family always included in decision making. Such kind of patient-centered care element can be achieved through some changes in these days, such as precision medicine and genetic-based diagnosis and technology-based tool, which was introduced just before, and also affluent economy can make this kind of achievement can be possible. In Korea, we have a national health insurance program. So we have a universal coverage for all citizens. Even though we have a fee-for-service system, but our medical cost is very low compared to other countries. So many Korean people has easy accessibility to the medical system. But we have some problem to do patient-centered care. We found that 10 years ago, because if we see the number of consultations per person and per doctor, our numbers are very high compared to other countries. These two figures shows the comparing number of doctor consultation per person with the OECD countries average. Our annual consultation per person is 3 or 4 times high comparing to OECD average, and also estimated number of consultation per doctor is also 3 times higher than average of OECD country. So this kind of qualitative approach in Korea, especially in primary care, resulted in the increased number of avoidable deaths. Actually, treatable death is the charge of tertiary care, but avoidable death should be achieved through qualitative primary health care. If we see avoidable death percentage in Korea, it is higher than OECD or England average. But our treatable death figure is very similar to OECD average or England average. So we have some qualitative problems, especially patient care needs in Korea. So 3 years ago, our government discussed the primary health care team, and we launched the new NCD management model at primary health care setting, which include registration. Actually, before this new model, the Korean people was not registered in primary health care. But through this model, 10% of primary health care actually involved this model, and the patient can be registered to primary health care, and they are followed continuously to the primary health care. After registration, the patient have to start to develop a care plan with the discussion of primary health care through the in detail medical interview, physical exam, and the lab test. And primary health care team spend more time and energy to understand what kind of problem the patient have. So they developed a new care plan, very comprehensive one, and they start to manage and care the patient problem through care with the care coordinator. They start to develop the care team in primary health care to do the patient-centered care. Actually, the government supports some financial support for this team building, and they do the annual care plan maker through this kind of model. So some model in this new program is a patient-centered team approach. Primary health care team can do patient-centered care with the coherent and identifiable private provider team, and they start to have a relationship with individual patient. They understand the patient's special needs and individualized need. And they made a patient-centered care team. And this team work with the primary health care provider and the patient together. And they start to achieve their discussed goal, health goal. And the team-based care, we call care coordination, and included not only primary health care provider doctor, but also nurses and the pharmacists and the managers and the many steps together. And they work together to solve the patient's problem. And they also start to survey patient-reported measures, not only clinical outcomes, which was handled before, but nowadays they start to receive and survey what kind of problem the patient have and what kind of experience the patient do. So actually, as soon as we started this new model, we experienced COVID-19 pandemic period. So it was really accidental, but we found that this kind of a new model worked through the COVID-19 pandemic experience, because many patients already visited through the primary health care provider. They can have a good communication with the primary health care provider. So they receive not only medical support, but also preventable support, such as the mask, the importance of mask the patient received through their primary health care provider. So their experience started better and better. And we already made a community consortium, and this consortium work to defend the COVID-19 pandemic accident. And also the care coordinator helped the patient to manage not only the COVID problem, but NCD problem together. And also government gave the payment for this kind of a new model. So this support actually helped the primary health care team to the continuous NCD care through COVID-19 pandemic period. Actually, this kind of communication made the Korean government and the national health insurance system in Korea start the temporary permission of telecare or prescription. So this kind of change make the primary care health team manage the NCD problems for their patient. So the government and the national health insurance system supported 30% additional payment for telecare and teleprescription, because it started very abruptly. So primary health care teams, the burden was very high, so they supported financially. And also they supported 1 month advanced payment during COVID-19 for primary care to care their registered patient. So fortunately, we found until now, weekly access deaths during COVID-19 pandemic in Korea is very similar to before. So I summarize the Korean initiatives to increase patient-centeredness in primary health care of Korea through new NCD management model, which consists of a registration and care plan and the care coordination team to understand and to support the patient individually. And the government and the national health insurance system support this primary health care to do patient-centered care with the bundle management payment. And we hope this kind of change increase patient participation in decision-making, such as shared decision-making and informed choice. And through more individualized and customized service, we hope the patient-reported outcome measures better and better. And we expect the better responsiveness to patient needs, because we already have some experience of a team approach, and it really worked during the COVID-19 period. Thank you.
Thank you very much, Professor Cho, for giving us this very informative presentation on the Korean initiative to increase patient-centeredness in the primary healthcare system. Now we will turn to the patient perspective. Our first presenter is from Korea and is Secretary General Elvis Lee of the Korea Spinal Cord Injury Association. He's been living with a spinal cord injury for 33 years and is involved in activities promoting the importance of early rehabilitation and vocational rehabilitation for people with spinal cord injuries.
안녕하세요. 저는 사단법인 한국척수장애인협회 사무총장 이찬호입니다. 우선 한국과 덴마크의 의료 시스템에 관한 정보 교환 세미나에 초대하여 주셔서 감사드립니다. 저희 협회를 간단히 소개해드리면 2004년 4월에 처음 설립된 전국적인 조직으로 현재 4천여 명의 척수장애인 회원과 함께하고 있습니다. 협회에서는 척수장애인들이 기회와 권리를 가진 사회의 주류로서 살아갈 수 있도록 지원하는 다양한 역할을 하고 있습니다. 척수장애란 사고나 질병의 원인으로 뇌와 신체 사이에 정보를 전달하는 주요 신경다발인 척수가 손상으로 인해 다양하고 복잡한 후유증과 합병증을 동반하게 되는 신체적 어려움과 심리적, 사회적, 경제적인 어려움을 겪는 중도, 중증, 중복의 장애 유형이고 거의 휠체어를 사용하는 특성이 있습니다. 대부분 20대 이후 성인기에 장애를 가지게 되는 중도 장애인입니다. 즉, 사회 경험이 많아서 제대로 재활을 한다면 충분히 세금 내는 장애인이 될 수 있는 장애 유형입니다. 척수장애가 가지는 여러 신체적인 특성 중에 가장 힘들어하는 부분이 스스로 배뇨가 어려운, 즉 스스로 소변 보는 것에 어려움이 있는 신경외성 방광을 가지고 있다는 것입니다. 이런 특성은 자존감의 하락과 이로 인하여 사회복귀에 중요한 걸림돌이 됩니다. 금일 제가 공유드리고 싶은 부분은 이러한 걸림돌을 해결하고자 하는 제안들입니다. 저 또한 33년 전에 척수장애를 가지게 되었고 왕성하게 활동하는 당사자로서 이런 제안을 하게 되어 더욱 의미가 있다고 생각됩니다. 2013년 7월 선천성 소변 배출에 어려움을 겪는 신경외성 방광 환자에게 자가도뇨 소모성 계교, 즉 카테타 구입 비용으로 매월 약 24만 원이 건강보험에서 요양비 적용이 되었습니다. 무척 좋은 소식이었지만 안타깝게도 같은 증상을 가지고 있으나 선천성이 아니라는 이유로 후천성 신경성 방광 환자인 척수장애인은 여전히 건강보험 지원을 받지 못해 소변 배출을 위해 월 24만 원 정도의 비용 부담을 안고 있었습니다. 소변 보는데도 돈이 필요했습니다. 비용 부담으로 재사용 카테타를 사용하다 보니 요로 감염, 방광, 요관 역류 등 합병증을 겪고 있었고 이는 사회활동에 커다란 걸림돌이 되었습니다. 이런 문제가 2015년 보건복지부 국정감사에서도 논의되었습니다. 같은 증상에 동일하지 않은 혜택이라는 안타까운 상황은 보건복지부의 현명한 결정으로 선천성 적용 약 5년 후인 2017년 7월에 후천성 척수손상 환자에게도 동일한 급여 혜택이 적용되어 개선이 되었습니다. 이로 인해 카테타의 복잡한 급여 과정이 간소화되고 재사용으로 인한 감염 위험이 감소될 수 있었습니다. 결과적으로 일상과 사회로 복귀하는 데 걸림돌이었던 카테타 관련 걱정이 덜해져서 척수장애인들의 사회 참여가 활발해지고 궁극적으로 그 혜택이 다시 사회로 순환될 것이기에 매우 긍정적인 제도라고 생각합니다. 무엇보다도 저는 동일한 증상에 동일한 혜택이 적용된 것은 평등이라는 가치 실현에 큰 의미를 부여하고 싶습니다. 사실 제가 오늘 말씀드리고 싶은 주제어는 바로 이 동일함입니다. 자가도뇨 소모성 보험이 척수장애인의 삶과 건강에 매우 긍정적인 영향을 가지고 있는 제도지만 아직 해결돼야 할 과제가 몇 가지가 있습니다. 첫째, 다른 의료기관과 동일하지 않는 요양병원. 같은 신경위성 방광질환임에도 요양병원 입원 중에는 동일하게 적용되지 않는다는 것입니다. 다수의 척수장애인들은 사회로 가는 마지막 경로로 요양병원을 선택하기도 하고 퇴원 이후에도 여러 이유로 요양병원에 있는 경우가 많이 있습니다. 하지만 요양병원에 입원 중인 경우에는 요양비 혜택을 받을 수가 없어 다시 유치소변줄을 사용하거나 전액 자부담으로 카테타를 구매해서 사용할 수밖에 없는 안타까운 일들이 벌어지고 있습니다. 사회복귀를 위해서는 배뇨 훈련이 중요한데 오히려 뒷걸음치는 안타까운 일이 발생하곤 합니다. 그 원인은 요양병원에서는 정액 수가제로 이미 입원 혜택에 도뇨 관련 제품이나 관련 행위가 포함되어 있기 때문이라고 합니다. 하지만 안타깝게도 요양병원에서 도뇨와 관련되어 도움을 기대하는 것은 현실적으로 어렵습니다. 척수 환자 스스로가 방광 문제를 해결해야 합니다. 도뇨 요양급여 혜택은 받을 수 없는 말 그대로 보험 사각지대이며 마치 2017년 이전으로 돌아간 과거와 같습니다. 이런 이유로 많은 요양병원에 입원 중인 신경성 방광 환자를 가진 환자들은 감염에 노출되거나 아주 불편한 방식으로 소변을 해결하고 있습니다. 더 가슴 아픈 것은 이러한 복잡한 규정을 모르고 구매했다가 70여만 원이나 해당되는 좌우담을 몇 달 뒤 환수 조치 당하는 것입니다. 이 문제를 해결하기 위해서는 첫째, 요양병원에서 안전하게 도뇨 서비스를 하거나 둘째, 도뇨와 관련된 비용을 정액수가 항목에서 제외하여 자가도뇨 소멸성 보험 혜택을 받아 카테타를 직접 구매할 수 있도록 실질적인 제도 개선이 필요하다는 것입니다. 둘째, 다른 질환과 동일하지 않는 도뇨 교육 수가. 자가도뇨는 환자 스스로가 평생 스스로 해야 하는 행위입니다. 만성질환 치료의 특성상 치료에 대한 장기적인 수능도가 중요하며 이를 위해 의료기관에서 받는 첫 교육이 가장 중요합니다. 당뇨, 장루, 요로 등과 같은 질환에는 의료기관으로 하여금 양질의 교육 적용이 가능케 하는 보상체계, 교육수가가 확립된 것과 달리 자가도뇨에는 아직 교육수가가 없다고 합니다. 보통 도뇨교육에 40분 가까이 소요되는데 의료진에게 무료의 양질의 교육을 해달라고 요청하고 피드백을 받는다는 것은 현실적으로 무리라는 생각이 듭니다. 그러다 보니 병원마다 도뇨교육 하는 법도 달라서 도뇨를 하는 환자 입장에서는 혼란스럽기도 합니다. 올바른 치료에 대한 적절한 교육이 이루어질 수 있도록 도뇨교육에 대한 건강보험 보장이 진행되면 결국 치료의 수능도가 증가하여 사회적 이득이 더 크다고 생각합니다. 셋째, 8년 전 가격과 동일한 요양급여 기준금액입니다. 자가도뇨 소멸성 제로는 1일 최대 6개까지 처방이 가능하며 지원하는 기준금액은 1일 9,000원입니다. 환자가 건강보험공단으로 처방전과 세금 계산서를 제출하면 이 기준금액의 90%를 건강보험에서 환자에게 현금으로 지급하게 됩니다. 아쉬운 점은 이 규정이 생긴 것이 무려 8년 전인 2013년이라는 것입니다. 당시 9,000원이면 젤이나 장갑 없이 물을 부어 사용하는 제품이 가장 사용하기 편리하였고 그 제품 기준으로 6개까지 구매 가능하였습니다. 최근에는 물을 붓지 않고도 바로 사용할 수 있고 삽입 시 통증을 줄이거나 제품의 사이즈가 작아서 남의 눈에 띄지 않게 신변치를 할 수 있는 등 기능이 개선된 제품들이 출시되었고 직장 및 학교 등 사회활동을 하면서도 사용하기 더욱 적합하게 사용자들의 기대감이 높아지고 있습니다. 그러나 문제는 그런 제품은 9,000원으로 4개밖에 구매하지 못한다는 것입니다. 소변을 하루에 4회만 볼 수 없는 노릇이라 많은 분들이 울며 거저 먹기로 부족한 수량을 자부담으로 구매하거나 불편함을 감수하고 오래전에 출시한 제품을 사용하는 것이 현실입니다. 자가도뇨 소멸성 제로의 도입 목적대로 신경성 방광 환자를 포함한 요양비 지원 대상자의 건강 증진과 경제적 부담 완화를 위해 기준 금액의 조속한 조정이 이루어지기를 기대하는 바이며 이에 대한 구체적인 방안을 논의하는 자리가 열리기를 희망합니다. 대부분의 척수장애인은 삶의 중도에 장애를 갖게 되어 사회 경력이 단절됩니다. 하지만 척수장애인도 최적의 의료 지원과 체계적이고 준비된 사회복귀 훈련, 환경 개선이 있다면 사고 이후에도 다양한 분야에서 활발한 사회 참여가 가능하다고 생각합니다. 그 첫걸음이 완전한 배뇨 환경을 구축하는 것입니다. 이를 통해 사고 전보다 향상된 일상의 삶으로 복귀하여 세금 내는 장애인이 될 수 있습니다. 아무쪼록 코로나19로 어려운 상황이지만 가장 힘든 시절은 지났다고 믿고 싶습니다. 모두 건강하시길 기원드리며 척수장애인뿐만 아니라 같은 증상의 환자들이 올바른 지원을 받을 수 있기를 희망합니다. 새해 복 많으십시오. 감사합니다.
Thank you very much. We are very grateful that Secretary General Lee would deliver insights and also challenges from the Korean patients living with spinal cord injuries. Our next speaker will give us a perspective from the Danish patients. Mr. Jonathan Slosh is the CEO of the General Practitioners Organization in Denmark and has 20 years of leadership experience, including from hospitals and the healthcare organizations. Please, Mr. Slosh, the floor is yours.
Thank you very much, and thank you for the invitation to address this very important topic. I'll just test my computer skills and see if I can share the screen here. So, yeah, I would like to talk a bit about the general practitioner as a gatekeeper and advisor in the Danish healthcare system and the patient-centered approach. In Denmark, a general practitioner is a specialist, the same way as a cardiologist or a surgeon or something like that. And all Danes have their own general practitioner. That's in the law, that you have access to your own general practitioner. Basically, in the Danish healthcare system, the GP is a gatekeeper to the rest of the healthcare system. You cannot see a specialist or the hospital without referral from a general practitioner. So I think that is a special thing in the Danish healthcare system. This means that almost all Danes are in contact with their GP every year. When we look at the statistics, we see that the average is 3 physical consultations, 2 email consultations, and 2 phone or video calls a year, meaning 7 contacts per year for each Dane. However, once you get older, the 70-year-olds patients, they have about 10 contacts a year, and the 80-year-old patient, they have 15 contacts every year. So infants and the elderly are the patrons of general practice. They are the ones who are our frequent flyers, if we can use that term. The general practitioner is a gatekeeper and a gate advisor for the patient in the healthcare system. And if I should try to visualize what are the tasks of the general practitioner. Well, one thing is that they do the initial diagnostics. They are reactive, meaning that when the patient contact them with some sort of symptom, then the GP has the task to make the initial diagnostics. But also treatment. About 90% of all treatments in the healthcare system is done in the GP's clinic. But obviously, sometimes they have to refer the patients to hospitals or specialists, and then they advise the patients on how to what they should expect from the next level of treatment. The GP also has a task of conducting proactive chronic care, including trying to coordinate the care between hospitals, other primary care in the municipalities, and within obviously the GP's own clinic. When we look at preventive tasks, they are in the field of chronic care, child care, immunizations, neonatal and maternity care, lifestyle advice, etc. So basically, most of the patient-centered preventive tasks are done in general practice, whereas the municipalities, they take care of larger groups of preventive care. So, but in the case where the GP has referred the patients to hospitals or specialists after the hospital have done the final diagnostics and have finished the initial treatment in the hospital, then the GP will take over again for the long haul of the patient's treatment. So typically the hospital task is the final diagnostics and the initial treatments, and then the GP will take over again. Then the question is, why is the general practitioner necessary when you have a patient-centered approach? That's because the heavy users of the healthcare systems have comorbidity. I mean, more than 50% have more than one chronic state of health, and hospitals are not very good at patients with comorbidity because the hospitals are very, very specialized. So one doctor can only see one kind of disease, and another doctor will have to take care of another kind of disease, etc. So if you have comorbidity, you risk having many simultaneous treatments at the same hospitals, which are not coordinated. Obviously, a gatekeeper function in the healthcare system reduces cost to hospitals a lot, because patients cannot see a hospital specialist without being referred by a GP. Also, the GP is very close to the patient's local community, which means that collaboration with others when it comes to lifestyle changes is more feasible. What we see from research is that the care in the general practice, for instance, in the field of diabetes, is of very high quality and much less expensive than the similar treatment in a hospital outpatient clinic. A speciality of the Danish GPs is that they stay in the same practice for many years, which is why they're sometimes called family physicians, because they know the grandmother, the mother, and the child. They have known them for many years, and this facilitates, which we can also see in research, good care and a very high level of compliance when there is a well-established relationship between the GP and the patient. If I should illustrate a patient journey in Danish healthcare system, and this is my final slide. This is a diabetes patient, and if you look from the bottom here, it will typically start with some sort of lifestyle discussion, primary prevention, meaning you should change your diet, you should stop smoking, you should begin exercising. These are discussions that the GP can have with the patients. At a later stage, the GP will begin to conduct screenings of different sorts. And later on, when the illness is progressing, there will be symptoms, and the patients will once again seek the general practitioners. Why do I have this symptom? The GP will then do the initial diagnosis, and the GP will begin monitoring and treating the patients. At a later state, the GP will say, "Now I need help from a specialist," and the GP will refer the patient to specialists. This could also be a foot specialist when it comes to diabetes, or a specialist with the eye area and stuff like that. And then later on again, when the patient gets very sick, then the GP has to give up because now the patient gets a stroke or a myocardial infarction, and the patient will be hospitalized. And this treatment will obviously take place in the hospital, and there will typically be more hospitalizations. But in this area, the GP tries to follow the patient and coordinate these things. And yeah, in the end, there will be death, of course. We all die one day. The GP will also have a job when it comes to support for the bereaved in the family. So as you can see, the GP has most of the will have most of the task in the beginning and the middle of the patient journey, and then later on hospitalization will probably be inevitable, and then you die, and then the GP will do the rest of the support. So this is a brief introduction to what general practice is in Denmark and how it might look from a patient perspective. Thank you very much.
Thank you very much, Mr. Sloss, for sharing these insights from the general practitioners in Denmark as well as from the patient journey. We will now turn to a presentation on how new technologies are being applied to the benefit of the patients in Korea. Our speaker is Ms. Moon Cho, who is an associate professor at the Korea Advanced Institute of Science and Technology, KAIST. Please, Ms. Cho, the floor is yours.
Okay, good morning and good afternoon, everyone. And I'm so honored to be a part of this wonderful webinar. And I'm Moon Choi, Associate Professor at KAIST Graduate School of Science and Technology Policy Lab. And I'm running a lab called Aging and Technology Policy. And you can visit our website, aging.kaist.ac.kr. And I'm going to give a presentation about multidisciplinary collaboration approach to evidence-based for all the others living alone with chronic disease in Korea. So as a gerontologist, I'll give a talk about the aging process, why it is so important to have a public and private partnership. And as you may know, Korea is one of the leading countries in terms of the longevity revolution. And guess which country would be the next in the next 10 years? That would be Korea and France and Japan, etc. And Korean women will be the first the women around the world with the average life expectancy of 90 years. So that means our life course would be changed. So change the life course structure means that we might have 20 plus more years after the age of 65. And it means that if life is just one day, we have 5 or more hours per day. So what we are going to do those extra 5 more hours. But important thing is that living longer does not mean that living healthier. And we now have more years suffering from multiple chronic illness while living alone. And I really like this theoretical framework, and I attended the forum and the Professor Jacqueline Smith at the University of Michigan, and she gave a conceptual idea about what the third age means and what the fourth age means. And so aging process starts around 50, and after the retirement, we have a very active, healthy years. We can do anything that we want. And it's called the third age. And those term was very popular in Europe. And there are lots of, magazines and journal articles about, celebrating third age. We call them young old. But social concern, and also today's webinar is about the first age. That means inactive years, the time that we need help from other people. Also, those are often over 85 years old. We call them oldest old, and also multiple chronic illness. So from the public health perspective, the ideal goal is to maximize third age and minimize first age. And primary health care is very important to extend the third age and minimize birth age. So it's sort of the downing process from the third age and first age, and before getting in the hospital or hospitalized or institutionalized, we all go through the frailty, the phases, and we might not have a very serious illness, but have some chronic illness that we needed to handle. And one of the important social concern about all the population is falls. So sorry for that, the figure is in Korean, and there is a report that increasing number of people suffer from falls, and one of the largest accident that threaten the safety of all the people are falls. And one of the TV show that I loved is this one. This is about the four ladies, and they are former actresses or singers, and all of them are widowed or divorced, and they started to live together. And one main character that the Moon-suk, and she's an actress, and it's very interesting. She said that I always wear the rubber shoe, and this is very old-fashioned Korean traditional shoes. It's very non-slippery, and also it doesn't look the beautiful. But she says that the reason is that her the mother passed away because of falls. After that, she started to wear non-slippery these rubber shoes, and I felt this is one of the story that why we needed to be very cautious about the frailty and also the more better patient-centered primary health care. And I would like to introduce what kind of the technology have been employed in this sector. And there's an increasing number of applications. It's called the Personal Emergency Response System. And the primary client or patient are upper class or lower class and near under poverty. It's very interesting when the technology is employed. There are two groups: those who can buy by themselves with the asset, or the other group is subsidized by the government. So interestingly, upper middle or lower middle classes are people who got the technology the last. And I had some field trips and field study. And KAIST has a partnership with the Classic 500. This is one of the most luxury and upscale, fine kind of the condominium, the apartment. And it provides this large flat, and it has some technology. For example, the patient living here can get their blood pressure tested, and also if they have diabetes, they can check their the blood levels and daily basis, and all the information goes to the hospital. And also there are sensors on the ceiling, and then it detects the motion. If there's no movement for say that 6 hours, it automatically goes to the social workers or the staff or nurses, and then they can check in whether their the lieutenant is okay or not. And also there's an emergency alarm near the bed, so if they feel pains, they can push the button and get the service. And also in the healthcare, the gym, the indoor gym and fitness center has some kiosk, and all the people can get in and check in, and then check their the body index, and also they can get some data. And this is an example about how the system operates in very the upscale the housing. And the other side of the society is the government program. The Korean government started this program about 20 years ago, and it's run by the Ministry of Health and Social Affairs. And here is the user's house, and then there are many sensors. And if the sensors detect the fire or gas, it goes to the gateway, and the information automatically goes to the 991 and over the social workers or hospitals, and that's just sort of the system. But again, this is for the people near or under poverty, supported by the government and to be eligible for this service, or the person should live alone. And when I visit one of the patient, and there's a motion sensor like this near the door, and also the motion detector, and also the gas leaking, the sensors, and gateway looks like this. It looks like a telephone. It's very easy, have a few buttons. So one is 991 in case of fire. Also, there's 3 buttons, and automatically goes to the healthcare team. And once per season or once twice per year, the staff will visit the client's house and then explain, how the system works, and then listen to their stories. And also, there's a few houses with the camera, so you can see the camera on the ceiling. So if there's there's an alarm that there's no movement in the house for 6 hours, the camera automatically, open and take a photo and send it to the central system in case of the emergency. And also, this is one of the most traditional, old-fashioned sort of necklace type of the emergency button. And this is one of the innovation that how the technology developed by the private company can be deployed in the larger population to manage the chronic illness or in case of the emergency system. And because of the COVID-19, there's increasing needs for the untapped or remote caregiving and healthcare services. The Korean government decided to expand this service beyond the people under or near poverty. Also, the government started to upgrade or started to deploy more advanced gateway. So you can see the photo, the number 2. The old one was sort of the telephone type, the gateway, but now it's more tablet computer. So it just started this month, and this is the first photo that few older persons got this tablet. And so using this tablet, the older patient can talk with the healthcare team and also can get some emergency alarm services. And after these case studies, I have 4 policy recommendations that might also give us an implication on Denmark. The first one is that one of the most important thing about using the technology, the information communication technology in healthcare sector, especially for aging population, the number 1 is affordability. There are lots of fancy technology, more than we can imagine. But if it's not affordable or if it's more expensive than labor cost, it never adopted. So I wrote this paper with my student. The title is a prosthetic arm customized product. So it's a little bit joke, but there are lots of fancy, advanced technology like prosthetic arms, but it's more than 1 million, and who can afford that? So when we develop technology in healthcare sector, it's very important to think about affordability. And another one is the serendipity. That means that when you develop technology, we try to develop new, but it costs a lot of research and development funding. And it is very important to use the existing technology and find a good way to use of it. So for example, tablet computer or AI speaker, there are many fancy new technologies that would be affordable, and that might be very useful to deployed in a healthcare sector. And the next one is about data justice. And there's a small data movement in the era of big data. That means that people would prefer big data, but the important thing is the high quality data. So even if it's small data, it would be a very secured and also improve the patient's quality of life. I think that's good enough. So we need to think about the sort of the power issues between the authorities and the government and private companies. So data justice is a very important issue. And also we did the surveys and interviews with older people about their willingness to share their personal health information. There are lots of hesitancy, and also there are lots of concerns about privacy issues. So when we develop data, also the system, it's very important to think about these 4 important components and issues, both in South Korea and Denmark. That's all I have, and thank you for listening my presentation, and thank you for including me in this wonderful webinar. Thank you.
Thank you very much, Moon Chie, for that very interesting presentation. I think that gave us very valuable insights. Before we move on to our next speaker, I would like to mention to you all that we have opened the YouTube platform for questions. We are ahead of time, so we will have time for some questions after our last speaker. For those of you who are watching through YouTube, you will just have to refresh your browser and the option for posing questions should appear. Now we will turn to the Ministry of Health and Welfare of Korea. Director Ko of the Health Policy Division will give us a presentation on how public-private partnerships are utilized to the benefits of Korean patients and to the benefit of Korean healthcare system. Please, Director Ko, the floor is yours.
Good afternoon. First, I would like to express my gratitude for inviting me to the Korea-Denmark seminar. I also want to thank all speakers for your presentations. The topic for my presentation today is Korea's primary healthcare and, in particular, the public-private partnership in hypertension and diabetes management. The prevalence rates of hypertension and diabetes stand at 10 through 30% in Korea, and the mortality rate of diabetes is high in Korea. Korea's public primary health care includes health centers, each number about 256 nationwide, and the private primary health care includes clinics, each number about 33,000 nationwide. In Korea, health institutions are being operated individually without a network between the public and private sector, and patients are served mainly by health clinics operated by specialists that lack the integrated management of patients. This leads to the need for a structured system for public-private partnership. We need to create a network to connect central and local health infrastructures through institutions such as primary health support centers or clinics. We have consulted primary health clinics from the early stage of the pilot project so that they can participate in the system development, including a service model and user screen. I would like to introduce the 3 strategies that we are working on for cooperation between public health centers and the private sector. This following figure shows the governance for chronic disease management in primary health care in local communities. First is a cooperation model of a local steering committee. Local medical associations can apply for the pilot project if the MOU signed with a health center or a branch of NHIS. NHIS means National Health Insurance Service as a precondition for application. Currently, 75 local associations are participating, and last year, each association held one local steering committee meeting on average amid the COVID-19 pandemic. This project is an application-based pilot project that targets health providers at the local level, such as the local medical associations. The NHIS provides monthly monitoring data to each region, including the number of patients by clinics, to help monitor the progress of the project by regions through big data. I heard that these data are very helpful for health centers to understand the current status and set plans at the local level. The following data shows monthly status of patient management by clinics, and the doctors in clinics provide feedback on the data collected by the NHIS. The data includes self-reported numbers like blood glucose by patients. Our second strategy is to have local communities identify patients with untreated diseases and connect them with the clinics. As around 2.1 million people among 11 million hypertension patients and 2.2 billion among 5 million patients, diabetes patients, are untreated. The public sector can carry out the identification of patients under using medical services. The third strategy is for private clinics having difficulties in providing education for healthy lifestyle habits. In this model, clinics can use the network with the public health resources for patient management. To that end, the public sector can develop programs and provide them to clinics. Following this education program had been provided in 2019. Through this policy support and cooperation, we are looking forward to seeing positive results that complement the weakness of the private sector's chronic management in primary health care. Thank you very much.
Thank you very much, Director Ko, for your very impressive presentation. We have now heard from our last speaker, and we're very fortunate to have some time for some questions. So I would like to direct the first question to Ms. Rist from Healthcare Denmark. And the question is, what are the largest challenges in terms of finding solutions which specifically targets patient needs?
So I think we need to look at the risk of patients falling in between the systems, because our system take care of different things. For example, in Denmark, the municipalities has the responsibility for rehabilitation, for example. The regions has the responsibility for the hospitals. So sometimes there's a risk of deconnecting in the treatment process. And we also heard from the Korean Spinal Cord Injury Association that they had this less optimal payment and reimbursement system. And we also see that kind of stuff in Denmark. So I think a very good tool is to map the patient journey to see where are they falling into these holes and making sure that we close them. And of course, when we map this patient journey, to do it together with the patient, because they are the ones who have the insight. And maybe also actually to include the general practitioners, as we also heard before, that they actually have a quite good overview of how the patient journey is.
Thank you very much, Ms. Rist. And I can actually see that this question has also been posed to Associate Professor Che. So, Ms. Che, I would like to ask you also, what do you think in the Korean context are the largest challenges in finding specific solutions that target the patient needs?
I think one of the primary challenges would be the data issue, because there are the data, because of Korea has a national health insurance system, we have very rich data, but because of the Privacy Act, it's very hard to connect the data. And as you know, that there are artificial intelligence or some machine learning techniques are so advanced, so we can provide some recommendation system or the personalized the services, but because of a lack of the big data, the linked data, it's hard to implement that one. And another issue would be the data bias. As you know, that when we develop an algorithm, the data is very biased by gender or age or even in races. So those data bias issue has another challenge to advance the customized or personalized patient services.
Thank you very much. So, Ms. Rist, is that also something that that you see in Denmark?
Yes, definitely. I mean, data is something that we are very occupied with. We're very lucky in Denmark. We have a huge data basement, or with a lot of data in Denmark, because we have this CPR system that goes back to the 70s. So we have a lot of collections, and our biobanks provide also a lot of great information. But we have also the GDPR, which we are struggling with to find a good balance, making sure that we have the agreement from the patients to use the data in the best possible way. And that is not a problem that's completely solved yet.
Thank you very much. We have another question that actually goes to both sides. So this is, what changes would you think that your respective healthcare systems in both Korea and in Denmark would need to make in order to become more patient-centered and in order to handle the aging population without using all the resources for healthcare? So I would like to ask if Mr. Schloss could give the perspective from Denmark, and then I hope that maybe Director Ko could give the perspective from the Korean side.
Thank you very much. Well, I believe that in Denmark we have to realize that the hospitals are not the best place to treat patients who have many chronic diseases, the multimorbid patients, because the hospitals are very, very specialized, and you will have to attend many different outpatient clinics in order to be treated, and that is very costly, and it is also very uncoordinated. So you need basically to move a rather large part of what traditionally has been done in outpatient clinics, to move that out to a mix of general practitioners and municipalities for the primary care. What you have with a general practitioner is a generalist, a doctor who knows something about several specialties. So they are basically the only doctor who are able to treat different kinds of diseases at the same time. And also, and this might be a bit provocative to some, but in Denmark we also always talk about that doctors are not very good at listening to the patients. They're not very good at talking to the patients. It's always the nurse that has to translate what the doctor has said. General practitioners are very proud to be the only kind of specialty that listen to patients. And that's what you need to do in order to make patient-centered treatment. You need to listen to the patient. I mean, if the patient has many problems, also social problems or poverty issues or family problems, then discussing with them that you need to exercise is futile. I mean, it's a waste of time, and it's also disrespectful for the patient that the doctor will continue to talk about exercise if being overweight is the least of the patient's problems. So you need to be able to listen to the patient and address the issues that the patient see as the most important. And I have to say that there are very few doctors from hospital specialties that are able to do that. But most of the GPs have learned how to listen. And I think that's an important issue. Thank you very much.
Thank you. Director Cho, do you also have some perspectives on this? Director Ko, do you also have some perspectives from the ministry side on this?
I also worry about the aging society in Korea. So now we will develop the private-public cooperation model and the cost and maintain the sustainable NHI system, IS system. That's all.
Thank you very much. And just I would also just ask, since you've been presenting on the patient-centered approach, Professor Cho, do you have any remarks to this as well?
Yeah, actually, the Korean medical payment system is a people service, but it gives a lot of burden to the patient and the doctors to the patient-centered care, because as you know, to implement the patient-centered care, you need lots of people and lots of money and effort to understand and to give a comprehensive service. But our technology is not complete until now. So we should change. In Korea, actually, we think about this change. We should pay for not just the people service, but we should pay for some performance or outcome measure. So the doctors and many medical providers give a focus to how give us good impact to patient outcome change with a small effort and money. So it is, I think, more important issues in Korea. Thank you.
Thank you, Professor Cho. I think you're definitely right on that. So we have a question from the YouTube chat, and that goes to Associate Professor Moon Che. What do the elderly think of living with monitoring technologies paid by the municipality, and on what conditions are they provided to the elderly person?
Thank you for the question, especially from the YouTube users. And we did some interviews with the older person using the technology, and they feel like safe because older persons living alone often concerned that the case of the force, and so they feel safe. Also, their caregivers also feel great, secured. But the problem is that the privacy concerns. When older person live alone, they also have some relationship issues with their family members. So they don't want to get their data out of their control. But often the data goes to the families and also the government too. And so there are concerns about privacy issue. and that would be the concern. But I feel it is very important to design the system, at the development stage of the system. It is very important to include the users. We call it user-centered approach, or in the WHO, the World Health Organization, has a sort of the active aging model, and it is very important to include the potential users at the beginning stage. So I think the lessons that we can take from the WHO model is that when we work with the private and the public partnership, it is very important to include all the persons, so what they think, what they feel, and what they need at the beginning. Because once the system is developed, it's very hard to change later. And I feel that's the message. Thank you.
Thank you very much. We have one last question, which is also asked to both the Danish and the Korean side. So maybe, Ms. Rist, maybe you will start with the Danish perspective. So this is, how will you handle the many elderly patients with multiple diseases in Korea? Do you think that, sorry, so that was for the Korean side. And do you think that your healthcare system can handle it as it is today? So, Ms. Rist, if you can please share that from a Danish perspective, how Denmark will handle the many patients with chronic diseases.
Yes, I think we will going forward have a lot of focus on chronic patients, and also, of course, in the elderly generation, where the chronic patients usually are multiple. As I mentioned earlier, we will probably have some political initiative later this year that will focus on this. And I think what we will do is to really take the focus from treatment to early detection and prevention. There's a lot to gain there, also in an economical way of looking at things. So exactly how that's going to be done, I'm not sure. We do already have a lot of initiatives going on with the recommendations for the municipalities how to handle this. But there's not a national plan for it yet, but that will hopefully come.
Thank you very much, Ms. Rist. And I would like to direct this also to the Ministry of Health and Welfare, Director Ko, if you could provide the Korean perspectives. So maybe I should just...
I already
the question is, how will you handle the many elderly patients with multiple diseases in Korea? And do you think your healthcare system can handle it as it is today?
I already answered the question. I also worry about the aging society. Until now, our NHIS system is good, but the society is aging. The problem of cost is very important to our system. So we just started for example, private-public partnership model, and then it can handle a little bit handle the aging society problem and system. I think our NHIS system can handle the cost problem, I think. Yeah. Thank you.
Thank you, Director Ko. And I said that was the last question, but actually there is one more from the YouTube platform. That is for Associate Professor Moon Chae again. The question is, in your perspective, what is the latest technology, app, software that you see most practical and helpful for the elderly population living alone?
Thank you for the question. And I give a talk a lot. There's no fancy the technology for all the people so far now, because when you say that what's the most the popular and the well-known technology for all the person we call general technology, we cannot think of any one single item. It's not the iPhone, it's not the Galaxy, and it means that there's no such technology. but there are some promising technology, and our lab, also our graduate school, started working with a private company called Cross Culture, and they have the Hyodol. It's an AI speaker, the toy, and then it's for all the people living alone. And then, you know, when they got that the Hyodol, they can touch the head or the hands, and it says that, you know, thank you, grandma, and you know, and did you take the medicine or did you take a pill? Or so they give us some exercise, the songs, and also the caregivers can control the toy with their app. So for example, if I have my mother in rural area, if I record my voice that, Mom, you know, have a good day and I miss you a lot, and the toys say that, you know, at certain times. So that way it's sort of the remote caregiving, and that's a very the advanced and developmental stage. But still, like, there's affordability issue, and as I mentioned, the privacy issue, and there are lots of hesitance of adopting the technology. But this question can go to the previous one. But I feel the future generation of older people, we call that baby boomers, or even the younger generation now. But when they get older, I think they can use technology more easily, and lots of technology to be more advanced. And so I think the future would be quite different. You know, you can imagine that every older people are very good at using smartphone or some new technology, and that would be quite different. Also, the Dr. Risk had something to say, and I saw that she raised her hand.
Yes, please. Did you want to make a remark, Ms. Rist?
Oh, that's a long time ago. So, but I can also say regarding, I fully agree to this, that the new generations will be much more digital. And we talked about before about the elderly generation, how we can help them. I think we have a lot of good telehealth and also digital solutions for them already now. And they're actually quite well accepted in Denmark also by the elderly generation. That said, of course, there are some people that don't feel familiar with this technology, and we need to also be able to offer them some solutions. There was just a discussion about how you get the invitation for the COVID-19 vaccine, and they should go into the system and book a time at the doctor themselves, and it wasn't everyone who was quite okay doing that, and of course we need to address that. But I think in general, the new digital solutions are quite well accepted in Denmark. Thanks.
Thank you very much to you all for providing those informative answers. We've had many important interventions today, which definitely show the value of innovative approaches in the healthcare systems of both Korea and Denmark, and also of taking the patient-centered approach. I would now like to hand over to our ambassador, His Excellency Ejner Jensen, for his closing remarks. Thank you.
Thank you all for very interesting presentations. I myself is no expert, but I can say that I clearly understand the challenges we have with a population growing older and the chronic diseases that many have when you go older. And today I think we have had some very good insights into what can be done, how we can deal with it. And we need to deal with it because there's a huge cost involved in helping all these people. So we need to find the most smart way and the way forward for that. I feel that our two countries have taken a very holistic and inclusive approach to healthcare, to the benefit of the physical and mental well-being of our citizens. I hope this meeting has been inspiring to all of you, and that you can bring the ideas home to your respective organizations and use what is most fit for you. We will be following up with more events on primary healthcare during this year. We have a string of seminars, and I hope that some of us will be able to meet physically next time, be in the same room. It is always nice for company. But in the meantime, I must say, it's also great to be able to have people from Denmark, along with people from Korea, sharing their ideas here today. So I've been very happy to host this, and I look forward to host more seminars in the year to come. By finishing off, I just want to say you all deserve a very big applause for great work today. Thank you to all the participants and to the speakers, and this will be the end from our side today. Thank you.